great pleasure that so many countries are represented. 11 countries, including Norway, are here today, and we have been looking very much forward to this interaction with the patient organizations. A lot of our research is based on the goodwill of patients, so we're indebted to you all for participation and keeping up with all our letters, surveys, and so on. So we're very, very thankful for that. As Jette mentioned, this has not come to be without some funds, and Duocort has sponsored us, of course, the European Union, and the University of Bergen has provided funds, and also the Patient Education Center here has lent us this place to be for these days. So thank you to all our sponsors. Before I start, I just want to introduce my colleagues here. We'll begin with Professor Ole Kempe. He's, I would say, the godfather of Corleone. Has initiated, at least introduced me into the science of Addison's disease in the 90s, and been very active publishing in the field, so I'm indebted to his contributions. And then we have Professor Simon Pearce from Newcastle, who is very involved in the British Addison network and has done genetic studies on Addison's disease. And my colleague Christian Løvaas, he is working in the Addison group in Bergen, and has been very active in the studies. And then we have Dr. Sophie Bensi from Stockholm, also on the Swedish Addison research team. She works at the Karolinska Institute and Hospital in Stockholm. And beside her, Marianne Øksnes. She's an endocrinologist and a researcher in Addison's disease. Professor Badenhoek from Frankfurt will join us. He'll arrive later tonight, so join us for the meeting tomorrow. Martina is not here. Okay, so now you know the faces of the colleagues. This is probably very well known for you, but Addison's disease is looked upon as a rare disease. In Norway, it's 14 patients per 100,000 of the population, and there has been similar numbers reported from the UK, in Italy. I believe in Sweden they find the same prevalence. So at least in Europe, in the Western countries, autoimmunity is the main cause of the disease. Maybe 90–95% of the Addison patients have autoimmune Addison's disease. And, the typical for the autoimmune disease is antibodies against an enzyme, a protein in the adrenal cortex called 21-hydroxylase. And finding these antibodies was the discovery that Ole Kempe and his group did back in the early 90s, published in The Lancet in 1992. Typical for Addison patients is polyendocrinopathy. They have not only Addison, but they have often, at least in 50% of the cases, another autoimmune disease, most commonly autoimmune thyroid disease, hypothyroidism. Some also have Graves' disease. Another typical feature of Addison's disease is unspecific symptoms. Many patients can go for quite a while before the diagnosis is made. They may be tired, they lose weight, their appetite is not good, they have joint pain maybe, But there are some specific symptoms. Salt craving is quite typical, craving for salt. And those of you who have Addison's disease have probably experienced this craving for salt, eating licorice and peanuts and chips and so on. And also another typical feature of Addison's disease is the hyperpigmentation. Quite typical in this patient here with this brown creases in the hands. And this is from Thomas Addison's original publication in 1855. Addison was interested in dermatology and skin diseases, and he noted this hyperpigmented patient. He was the first to connect this clinical picture with disease in the adrenal gland. As I told you, many patients have another autoimmune disease. Among Addison patients, about 50% have autoimmune thyroid disease, and around 10% have type 1 diabetes. So we also use the expression autoimmune polyendocrine syndrome type 2 with these combinations with autoimmune thyroid disease and or type 1 diabetes. Then we also have a rare form of Addison called APS1, autoimmune polyendocrine syndrome type 1. These patients have hypoparathyroidism, they have low calcium levels, and many of the patients also have chronic candidiasis of the skin, nails, oral mucosa, but they don't have invasive candida infections. Behind this type is mutations in one single gene, so it's in a very valuable disease to study to learn more about immunology. This is from this landmark publication kind of started a lot of new research effort into Addison's disease. It had been known for some years that sera from patients with Addison's disease, when you incubated them on a slide with adrenal tissue, you could detect antibodies on that tissue. It was in 1992 that Ulle Kemp and his group published that this reactivity to the adrenal cortex was due to binding of antibodies to 21 hydroxylase. It's a protein that's expressed only in the adrenal cortex. And this is a gel separating proteins after their molecular weight, and the patients and specific antibodies react to the same band. And this is what we call immunoprecipitation experiments showing that the patient sera have reactivity to this protein, but not those without Addison's disease. And this measurement assay of 21 hydroxylase is now used in the clinic in the diagnostic workup to find out what the cause of Addison's disease is. And in our database patient registries, about 85% of the patients have antibodies. If you look at the newly diagnosed, maybe 95% have antibodies. But there are also other causes of Addison's disease. But it's a very useful assay to do in the workup of the patients. I believe most of the countries in Europe use this assay now in the diagnostic work. But how did Euradrenal come to be? Well, this is a rare disease, and what is quite typical of rare diseases is often that there's a lack of knowledge. There are few patients. The pharmaceutical industry is often not so interested because there's not a big market for any drug or treatment for these diseases. And few researchers can study large numbers of patients. So even if we know that autoimmunity is involved in the destruction of the adrenal cortex, we don't know so much about how the adrenal cortex is destroyed. We don't know so much about the natural course of the disease. How are the patients doing? What kind of complications do they develop? Is the treatment ideal? Actually, we treat the patients more or less the same now as we did 60 years ago. So there hasn't been much development in the treatment. And this is due, in many cases, to lack of patience, and there's no research animal model either for autoimmune Addison's disease. Many other diseases like type 1 diabetes have several research models that has been very useful and helpful to study pathogenesis, but we lack that in Addison's disease. So the objectives of the Adrenal consortium has been to study both more basic research questions, but also clinical related questions. So we study the pathogenesis, we look at the genes and the immune mechanisms that are operational in the destruction of the adrenal cortex. We have work packages on the natural course and epidemiology.